Good afternoon, everyone. iTech India welcomes all the participants for today's RDLS session. Today's topic is common comorbidities in CLHIV, and the speaker is Dr. Piali Mandal. Dr. Piali Mandal is currently working as professor with the Department of Pediatrics at Kalavati Saran Children's Hospital, New Delhi. She has done her post-graduation from Safdarjung Hospital and DM in Pediatric Oncology from AIIMS. She is looking after the Pediatric Hematology Oncology Division since 2014 and is actively involved with multi-centric projects related to Hodgkin's lymphoma and long-term follow-up of cancer survivors. We welcome you, ma'am, for today's session and request you to start the session.
Good afternoon, all. Thank you, Shweta, for introducing me. So today we will be discussing the common comorbidities in child living with HIV/AIDS. Will you be sharing the slides?
Ma'am, no, you are sharing the slides from your end.
Yeah, okay. Wait.
Ma'am, click on the slide and then next.
So the overview of today's discussion would be malnutrition, anemia and thrombocytopenia, hepatic dysfunction in CLHIV, chronic respiratory morbidities, and neurological morbidities in CLHV, along with few other comorbidities. So as we know that at the time of diagnosis of HIV, CLHIV may have a variety of clinical manifestation depending on the age and severity of immunodeficiency. These manifestations may involve one or more systems and influence the clinical staging of HIV, ART regimen, as well as the treatment for these conditions. The system involvement has a direct influence on the health status and mortality and an indirect influence on the ART adherence due to drug interactions and added pill burden. All the systems may be involved either directly by HIV itself or secondary by the other OIs. So what are the common comorbidities at the time of diagnosis? If you look at system-wise, then it can be infection, nutrition, GI system, hepatobiliary, hematological, CNS, respiratory, or soft and skin and soft tissue infections. So if you look at the infection, it can range from tubercular to bacterial, fungal, viral infections which could be localized or disseminated. Nutritional deficiencies. GI system can include recurrent or persistent diarrhea, oral esophageal candidiasis, or recurrent persistent oral ulcer. In hepatobiliary system, we can have hepatitis B, C infection or hepatitis due to other organism. Anemia and thrombocytopenia are common manifestations of HIV/AIDS or the therapy itself. In CNS, one can have delayed development, developmental regression, meningitis due to various bacterial or viral agents, including tubercular or cryptococcus or HIV encephalopathy itself. Coming to respiratory system, one can have recurrent or persistent pneumonia, bronchiectasis, sinusitis, chronic otitis media, or lymphoid interstitial pneumonitis. In skin and soft tissue, one can get bacterial fungal infection, nutritional dermatosis, scabies, molluscum, contagiosum, or purpuric eruptions. We take malnutrition as the first common comorbidity, which is extremely common in CLHIV, and infants and young children are more likely to present with wasting, whereas older children who have an intermediate course, they are likely to have stunting. Malnutrition is an important cause of mortality in CLHIV, especially in developing world, and children with mild to moderate malnutrition may be managed on an outpatient basis, whereas those with severe acute malnutrition, one need admission and therapeutic feeding. So how to classify these patients on the basis of some anthropometric indices? So from 0 to 5 years, we take their height, weight for age, length for age, and weight for length. And these are the indices which indicate the nutrition status, and thus helpful in dividing these patients into 4 categories, where the growth can be normal, nutrition status can be normal, they can be underweight, wasting, or stunting. So how do we classify? If you look at the indicators, weight for age, height or length for age, and weight for length. So if the SD score is fall between median or below less than -1 standard deviation, then they fall in the green zone, which is normal. And if the SD is -2, below -2 SD, and if the weight for age is less than -2 SD, we classify them as moderately underweight. If the height for age is less than -2 SD, we classify as stunted. And if the weight for length or height is less than -2 standard deviation, they are classified as moderate acute malnutrition. If these parameters are less than -3 standard deviation, they are classified as severely underweight, severely stunted, or severe acute malnutrition, respectively. We can use the anthropometry and clinical parameters to label them as severe acute malnutrition and moderate malnutrition. So if a patient has weight for height less than -3 SD or severe visible wasting, or mid upper arm circumference less than 11.5, or edema of both feet, then they are classified as severe acute malnutrition. Whereas if the weight for height is between -2 SD and -3, or mid-arm circumference is between 11.5 to 12.5, and without any edema or severe wasting, they are classified as moderate malnutrition. These are the WHO charts where you can classify. So this, the first chart is the less than 87 centimeter. This is for more than 87, how to use it. The left hand side is for the boys and the right is for the girl. You look for the weight and then classify their weight SD between in this group: median 1 SD, -2 SD, or -3 SD, and look at the corresponding length. So how to determine SD square for weight for length? So now you have the weight, you refer to the table for weight for length. As I said, left side for the male gender, right for the female. Find the child's length or height in the middle of this table. If the length or height is between those listed, you have to round it up. As we know, if it is 0.5 or more, then round it to the higher number. And if it is less, then round it to the lower height. Look is the child SD score for weight. The child weight may be lying between 2 SD score. If so, then indicate the weight is between
Requesting participants to kindly bear with us. Ma'am, you're on mute.
Sorry for the interruption. So if we indicate the weight is between 2 standard deviations, then we label it as between -1 to -2 standard deviation, and one can write this as less than -2 standard deviation. Measuring, coming to the next parameter, measuring the mid upper arm circumference. We can use the normal measuring tape also, but this is the common measuring tape which we use for measuring the mid upper arm circumference. How to read this? One has to locate the tip of the shoulder, the acromion, and after pointing out to the tip of the shoulder, one should look at the tip of elbow, and then place the tape at tip of the shoulder and pull it till the tip of the bent elbow. Mark the midpoint. Over this midpoint, put the tape and correct the tape tension, because if it is too loose or too tight, it may give wrong value. So you pass this tape through this hole, and the point of intersection gives you the value of the MUAC. If the child's value is more than equal to 12.5 centimeter, he falls into green zone. It means well nourished. And if it is between 11.5 to 12.4 centimeter, the child is having moderate acute malnutrition, which one can see falls into yellow zone. Red zone indicate severe acute malnutrition, where the MUSA is less than 11.5 centimeter. And how to check for the second parameter, how to check for wasting or severe wasting. So one has to look at the front view of the child and decide, is the outline of the child's rib easily visible? Does the skin of the upper arm look loose? Does the skin of the thigh look loose? So if you look at the child, one can see that the ribs are visible. The skin is very loose in the upper arm. Look at the back of the child. Again, we can see that there is a wasting in the buttock area. One can clearly visible the ribs from the back and the spine. So there is definitely severe wasting is there. Now coming, how do you check for the bilateral pitting edema? Edema in the SAM. It's okay. So how to check for bilateral pitting edema? Edema in the SAM starts from the dependent part, that is feet in the mobile child. As the severity of the edema increases, it extends to the legs. So usually this edema starts from the feet and then it goes upwards as the severity increases. In very severe cases, the edema can be seen in the upper limb or the face as well, which is known as anasarca. To check for edema, one has to grasp both the feet so that they rest in your hand as the picture is showing, and with one thumb we press on top of each foot, and approximately for 10 to 20 seconds one presses, and if there is a denting, it is suggestive of pitting edema. How to manage patient with moderate acute malnutrition? One has to assess their feeding practices, underlying medical conditions. One need to counsel the mother or caregiver so that they can give feeds in adequate amount, frequency, which is adequate energy density and are hygienic. Counsel for food diversity and active feeding, follow up after 15 days. Underlying medical condition is to be identified, like cleft palate, congenital heart disease, infections, etc. They should be treated or referred to higher center. And if there is no underlying medical conditions, one should counsel mother for feeding. Coming to management of severe acute malnutrition, we have to look for the independent additional criteria. Like if the patient with SAM has no appetite and has medical complication, he would require admission and need facility-based care, where he or she will be started on F75, followed by F100, or ready to utilize therapeutic feeds and 24-hour medical care. Whereas a patient with good appetite and no medical complications can be managed in community basis, where they are giving feeding and basic medical care. And a weight gain of 15 to 20% would be the criteria to label that there is a transition from severe acute malnutrition to normality. Whereas where the patient is receiving facility-based care, the discharge criteria would be reduced edema, good appetite with acceptable intake, where acceptable intake means that the child eats at least 75% of the calculated RUTF ration for the day. What are the indications for hospital management in cases of SAM? Presence of any emergency sign, presence of hypothermia, edema, persistent vomiting, where the patient is not able to retain anything, feeling very weak or apathetic, fever more than 39 degrees centigrade, fast breathing or chest indrawing, extensive skin lesions and eye lesion, dehydration, diarrhea with dehydration, severe anemia, purpura or bleeding tendency, and evidence of systemic infection complications. Are we taking questions now or at the end of session?
Ma'am, at the end of the session.
One can drop in the chat box also, so we
Yes,
can take at the end as well. So after malnutrition, we'll move ahead with the next complication. Yeah. So we know that anemia is a condition in which the number of RBCs is insufficient to meet the body's physiological need. So there are cutoff to label anemia. And in the age group from 6 months to 59 months, that is 5 years, anemia is defined as HP level of less than 11 gram%. From 5 to 11 years, less than 11.5, and more than equal to 12 years, any HP of less than 12 is labeled as anemia. Whereas for the respective age groups, severe anemia is labeled as less than 7 gram%, and from 5 to 12, more than 12 years, anything less than 8 is labeled as severe anemia. So anemia is present in large proportion of CLHIV, and the important cause of anemia is the anemia of chronic disease and the nutritional deficiency. Apart from this, we know that ART, like zerovodine per se, can cause macrocytic anemia because of induced marrow aplasia. Causes of anemia in CLHIV, if you look at the causes, they can be divided into two groups: decreased production or increased loss. So in decreased production could be because of certain deficiency like iron deficiency, B12, folate, or erythropoietin deficiency. Certain infections can lead to marrow suppression and decreased production like malaria, Kala Azar, HIV, CMV, EBV, parvovirus, B19 infection, tuberculosis, MAC, or histoplasma. Drugs like zerovodine, Septron, amphotericin B, they all can cause anemia. Anemia of chronic disease and the malignant involvement of certain malignancies can lead to decreased production in the marrow. If you look at the increased loss or destruction, then hemolysis, which include autoimmune hemolytic anemia or pre-existing conditions in the patients, GI bleed, like bleeding because of certain infections like CMV, Candida, or bowel lymphoma, or hypersplenism. How to evaluate a patient with anemia? First thing is to take history. A good history is very, very important to elicit the cause. So we need to ask about the symptoms which is relatable to anemia, like easy fatigability or irritability. Many times the symptoms are very, very non-specific. Anorexia, pica, looking very pale, poor school performance, dyspnea on exertion, palpitations, dizziness, or headache. We need to ask specifically for any blood loss in the form of epistaxis maligna, rectal bleed due to anal fissure, or menstrual losses in adolescent girl, chronic diarrhea, recurrent jaundice, history of drug intake apart from ART, like anticonvulsants or Septron, repeated blood transfusions, like in cases of bleeding disorder or thalassemia. Need to ask about the past history, where they will give history of any chronic infection, liver or renal disease should be ascertained. Family history should include any family history requiring frequent blood transfusions, any history of bleeding disorder, or history of recurrent jaundice or gallstone, which indicate presence of hemolytic anemia running in the family. The dietary history should include type of milk given after birth and the type and the age of complementary feeding, history of pica, which increases the risk of helminthic infection. In the examination, a head-to-toe examination is important to look for the signs of anemia, vitamin deficiency, lymphadenopathy, splenomegaly, and sign of congestive heart failure. Pallor can be assessed by comparing the child's palm with your own palm to judge for the severity of anemia. Presence of jaundice indicate possibility of a hemolysis. One should look for the presence of heart failure. The signs could be tachypnea, tachycardia, hepatomegaly, petechial rashes, lymphadenopathy, organomegaly points toward underlying lymphoreticular malignancy, angular stomatitis, glossitis, cholinergia, which point towards signs of vitamin deficiency can also be present. How to investigate patient with anemia? First and foremost thing is to send a CBC, where one should look at all the cell lines, and low HB suggests anemia and its severity. Peripheral blood smear needs to be sent. It is a must. Investigation easily available. So microcytic anemia is usually because of iron deficiency, but presence of thalassemia is an important differential diagnosis. Macrocytic anemia is likely to because of the B12 or folate deficiency, or zerovodine can itself lead to macrocytic anemia. And normocytic normochromic anemia is most likely because of the chronic infections or acute blood loss. And as I said, one need to check the other cell lines as well. So if there is a pancytopenia, one needs to rule out aplastic anemia or lymphoreticular malignancies as well. While we look at the CBC peripheral smear, do look at the reticulocyte count. Increased retic count indicates that marrow is functioning, and it could be because of chronic blood loss or AIHA. Coming to management of anemia, one needs to deworm these patients, and they should be dewormed once in 6 months. The dose of tablet or syrup of albendazole is 200 mg single dose for children less than 2 years of age, whereas beyond 2 years, the dose is 400 mg single dose. The nutrition deficiencies should be supplemented. The dose of iron therapy, iron is 3 to 6 mg per kg per day of elemental iron. Do check the preparation and check the content of the elemental iron in each preparation and calculate the dose based on the presence of elemental iron in that particular preparation. Iron absorption is best when taken on an empty stomach or in between meals. Anemia usually gets corrected over 2 to 3 months of treatment. Oral iron should, however, be continued for another 2 to 3 months to replenish the iron stores. And folic acid at a dose of 100 to 200 microgram per day is adequate to resolve the folic acid deficiency. We need to counsel them for intake of iron-rich food like green vegetable, peanut, jaggery, eggs, chicken, etc., milk or milk products are poor source of iron. And those with severe anemia or with or without CHF need to be referred to pediatrician. Again, those with megaloblastic anemia having pancytopenia should also be referred. And any clinical feature suggestive of hemolytic or lymphocytic malignancy should be referred. And those who are not responding hematinics, and first one has to check the diagnosis and the dose, the intake. Even if the HB is not improving, one should refer them to pediatrician. The next hematological complication is thrombocytopenia, which means platelet count of less than 1 lakh. Thrombocytopenia is also commonly encountered in these patients and may be the initial manifestation of the HIV infection per se. So the virus itself can lead to thrombocytopenia. Other etiologies are immune-mediated platelet destruction, thrombotic thrombocytopenic purpura, or impaired hematopoiesis. Marrow studies are needed for evaluation of the cause. Management is usually same as occurs in HIV non-infected children. Once cause like malignancy and aplastic anemia has been ruled out, most CLHIV with mild thrombocytopenia, they respond to ART itself. And any patient with persistent thrombocytopenia or aplasia should be referred to pediatrician for further workup. If there are no questions, we can move ahead with the hepatic dysfunction, or any question?
Ma'am, there are no questions in the chat box as yet. Any questions from the participants? They can unmute their mic.
So I'll move ahead with the hepatic dysfunction in these patients. It is not moving. So what are the main causes of hepatic dysfunction? We know that hepatomegaly and mild elevated liver enzymes are common in these patients, though chronic or progressive liver disease is unusual. So the causes can be co-infection with other viruses like hepatitis A, B, C, or E, CMV, EBV, co-infection with the mycoplasma complex or cryptosporidium, fatty liver, or drug toxicity. What are the clinical manifestations of any patient with having liver dysfunction? In history, one need to look at the jaundice, anorexia, nausea, vomiting, fever, right hypochondric pain, pruritus, or pale colored stool. And one should look for the icterus, hepatomegaly, or decreasing span of liver size, altered sensorium, irritability, altered sleep pattern, poor feeding, ascites, and bleeding manifestations. These are the signs of liver failure. If you look at the investigation which is needed for patients with hepatitis, one should look for the liver function test, which include direct and total serum bilirubin, the liver enzyme, SGOT, SGPT. Usually these enzymes are elevated. One should look for the peripheral smear to rule out malaria, screen for other viruses simultaneously, look at the complications, which means the low glucose level. So check for the blood glucose, check for the PTINR and electrolyte dysfunction. Presence of jaundice is indicative of an acute hepatitis, especially if it is a recent onset. Usually with a chronic liver disease, jaundice may be absent. It is essential to gauge the severity of dysfunction. That is there any hepatic encephalopathy or coagulopathy? How to treat this patient? One need to remove the potentially offending medications as per the ARV adverse events guideline. And if the child is on ATT, we need to institute modified anti-tubercular regimen and remove the all hepatotoxic drugs, support the patient nutritionally, and monitor for electrolytes and PTINR with proper rest. For hepatic failure, monitor the intestinal decontamination, lactulose, and neomycin, low protein intake, vitamin K, FFP, antibiotic, correction of dyselectrolytemia, antacids or H2 blocker, oxygen and or ventilation if needed. Presence of hepatitis and its severity and etiology influence the initiation of ART as well as the drug regimens. Many ARV, especially like nevirapine and protease inhibitors, have associated hepatotoxicity. And any patient with these complications need to be admitted. Coming to the respiratory morbidities in these patients, first is bronchiectasis. Bronchiectasis is a disease which is characterized by irreversible abnormal dilatation of the bronchial tree, and it is classified as WHO stage 3 disease. Persistent cough and fever with productive purulent sputum or hemoptysis should arouse suspicion for bronchiectasis. Clubbing is usually present. Chest examination will reveal localized signs which do not easily resolve with the usual antibiotic treatment. X-ray may show cystic spaces, occasionally with air fluid level and honeycombing appearance. How to manage? Acute exacerbation need to be treated with the adequate antibiotic therapy, and the duration may be prolonged for like up till 2 to 4 weeks, and postural drainage of the sputum. So chest physiotherapy is a very important part of management of bronchiectasis. Antibiotics should be carefully chosen to cover a broad spectrum of microorganisms, including gram-negative as well. Attempt should be made to isolate organism by sputum culture, induced sputum, or bronchoscopy. Treatment involves administration of antibiotic during acute exacerbation and bronchodilators as well. Surgical treatment may be necessary if the symptoms are severe or refractory to medical treatment, or the disease is limited to a particular segment or lobe. Second comorbidity of respiratory system is LIP, which is lymphocytic interstitial pneumonia. LIP is a stage 3 condition again, and it is a lymphoproliferative and non-infectious pulmonary disorder. It is characterized by diffuse infiltration of CD4 lymphocyte, plasma cell, and histiocytes in the alveolar septa along the lymphatic. Most common in children infected with HIV, especially those aging more than 2 to 3 years of age. The disease usually has insidious onset of mild but persistent cough with or without exertional dyspnea and breathing difficulty and associated clubbing. It should be suspected if the child does not respond or if X-ray finding persists or worsen despite appropriate antibiotic or antitubercular treatment. Treatment include bronchodilator and corticosteroid, short course for mild intermittent symptom or long course with tapering in cases of chronic involvement. So one has to remember that while evaluating a case with HIV with respiratory symptom, it should be remembered that the patient may have multiple diagnoses. So it can have more than one entity because the signs and symptoms are not very specific. It is not infrequent for the patient to have a TB and bronchiectasis, or TB and LIP, or LIP and bronchiectasis as well. The next system involved is neurological comorbidities. If you look at how the neurological system involved, so the virus enters the brain through infected monocytes and T lymphocyte that cross the blood-brain barrier, which leads to direct invasion of the nerves by the viruses, cause inflammation, degeneration, disruption of the neurotransmission, vasculopathy, and demyelination. In children with these changes occur in an immature brain, and hence the morbidity is far more severe as compared to adult counterpart. What are the risk factors of CNS involvement in HIV patients? The route of transmission. So if there is a perinatal transmission, obviously there's the highest risk of neurological comorbidity. Patients with severe immunosuppression, which leads to high plasma viral load in the blood and thus in CSF. And we have to look at the age. Highest incidence occur in the first 2 years of life, with incidence rates around 10% in the first year, 4% in the second, and less than 1% in the third year and afterwards. Presence of other comorbidity like prematurity, low birth weight, and poor nutrition status. So we know that if it is a perinatal infection occurring as early as when the infection is early, the chances of CNS infection is far more than if it occur at the late in the life. So what is the spectrum of manifestation? They can have HIV-associated encephalopathy, stroke syndrome, HIV-associated neurocognitive disorder, which can vary in severity from asymptomatic neurocognitive impairment to severe dementia. What are the general principles of management of these patients? CNS involvement in these patients can be subtle. We need to assess the neurodevelopment and need to look at the red alert sign in these patients, especially in the infants and toddler. Follow a syndromic approach to identify the etiology. Neuroimaging can be very useful, and early detection of the HIV infection through systematic follow-up and evaluation of HIV exposed patients and timely ART initiation is the key to mitigate CNS insult, and effective ART and to some extent can reverse the neurological signs and symptoms. So what are the manifestations in children less than 5 years of age and more than 5 years? The manifestations can be different. So as we know that if the patient is less than 5 years old, the patient can have global delay in the milestones, or there can be static or regression of milestone as well. They can have acquired microcephaly, progressive spastic paralysis, pyramidal tract sign because of basal ganglia involvement, ataxia or seizures. In older children, that is more than 5 years, there can be slow progression or regression of the learning milestones, attention difficulties, impaired cognitive function in the field of conversation, comprehension, perception, or motor activity. If you look at the HIV encephalopathy, which is the most common CNS manifestation in pediatric AIDS, it can occur in first few months of life and may precede signs of immune deficiency and other systemic manifestation of HIV. HIV encephalopathy is diagnosed if patient have any of the following signs for 2 months in absence of any other demonstrable positive organism. So what are the signs? Failure to attain or loss of developmental milestone or loss of intellectual ability, progressive impaired brain growth demonstrated by stagnation of head circumference, acquired symmetric motor deficit manifested by any two of the following signs, that is paraparesis, paresis, exaggerated reflexes, ataxia, or gait disturbances. So any one of them lasting for 2 months, where we have ruled out any infective cause, one should label them having HIV encephalopathy. How to work up? CT scan of the brain may show cortical atrophy and bilateral basal ganglia calcification. MRI films in HIV encephalopathy may show presence of cerebral atrophy, cerebellar atrophy, calcification of in the basal ganglia, signs of attenuation of white matter. HIV encephalopathy, even when arrested by ART, leaves residual cognitive and motor deficit with significant impact on independent mobility and daily living. Frequent association with lack of nurturing, a poor social environment, and parental sickness contribute to an overall poor development of these children. Thus, poor school performance and dropping out is very common in patients with HIV encephalopathy. How to manage them? All HIV exposed and infected children must undergo routine developmental assessment at presentation and during follow-up visit. So one can timely pick whether there is a delay or there is a regression of milestone. A detailed evaluation is needed for children with developmental delay, poor scholastic performance, or behavioral issues. They will need a referral to a pediatrician and psychologist as appropriate. Moving ahead with the other common comorbidities. Other could involve cardiac system, where cardiomyopathy is a very common cause of mortality in HIV. All components of these cardiovascular system might be affected during the course of HIV. It is likely that HIV-related cardiac disease has multifactorial origin due to HIV per se, secondary infections, other concurrent disease states, side effect of therapy, nutritional deficiencies, or yet unknown mechanism. Dilated cardiomyopathy is the most common cardiac complications of HIV infection in children and is an adverse prognostic indicator in patients with HIV infection. Zirconium has been implicated in etiology of cardiomyopathy, though its role has not been formally established. Patients living with HIV on zirconium-based ART should be monitored clinically for evidence of cardiac disease, and early atherosclerosis may be a new emerging disease in HIV-infected children. Next common complication is pulmonary arterial hypertension. It is a serious disease of the pulmonary arteries and characterized by increase in the pulmonary vascular resistance and pulmonary arterial pressure. It is defined as resting mean pulmonary artery pressure of more than 25 mmHg or mean pulmonary artery pressure following exercise that exceed 30 millimeter of mercury. The child usually present with exertional breathlessness due to inability of right ventricle to raise cardiac output with exercise. They can have symptoms like hemoptysis, chest pain, congestive heart failure, dizziness, syncope. How to diagnose and manage them? Chest X-ray may show cardiomegaly and pulmonary artery enlargement. ECG is usually diagnostic and with a right axis deviation and right ventricular hypertrophy with right axis deviation. HIV-associated PAH is confirmed only after other possible causes of PH have been excluded. Hence, all children with signs of PH need an urgent referral to pediatrician. So PAH could be because of bronchiectasis as well. So once the patient has been ruled out of other causes of PAH, then only one should label him as HIV-associated PAH. So this ends my presentation. Now we can take on the questions, if any.
Thank you so much, ma'am. There are no questions in the chat box. Any questions from the participants? Please feel free to unmute your mic. Ma'am, I don't think there are any questions.
So in that case,
ma'am, I'll just quickly run the feedback form for this session.
Sure.
The feedback form is now visible on your screen, requesting all the participants to please scroll through all the 4 questions and answer them. Requesting all the participants to please fill in the feedback form. Thank you so much, ma'am, for facilitating this session.
Thank you, Shweta, for having me. And thank you all the participants. I think we can end.
Yes, ma'am. Thank you to all the participants for patient listening. We have completed our series on the national guidelines for HIV care and treatment, and we'll soon be starting with our routine RDLS sessions. Thank you, everyone.